Okay, so today we're going to talk with Leah Bell. I'm really excited. She is helps folks get back to driving after all sorts of things, but we're going to kind of focus on stroke survivors and the return to driving. And I'm just going to let Leah talk about what her background is, and then we'll ask her some questions. So, Leah, tell us a little bit about sort of your background in general, what you do for
Okay.
your work.
All right. Sure, Shannon. So I'm an occupational therapist. I have been an occupational therapist for about 37, 38 years, but in probably the last 25, 28 years, I've been specifically dealing in the field of driving. I work in a rehabilitation setting, so all of the clients or most of the clients I see are currently in an outpatient program or they've graduated from outpatient therapy potentially. So I see clients who are really at the end of that rehab process, ready to resume their independent life as much as possible. So not only am I an occupational therapist, but I do have a special certification. I'm a certified driver rehabilitation specialist. There are only about, unfortunately, 450 of us in the country.
Okay.
Luckily, in the state of South Carolina, right now, there are 5 of us.
Okay.
So that's pretty good. There are some states that have none.
Mm-hmm.
And in my program, there are 3 of us, and we cover pretty much all of the upstate above Columbia.
Okay.
And we see people primarily in our clinic. There are occasions where we can travel, but that's pretty rare because there are a couple of programs in the state where those therapists, that's all they do. They travel
Travel to do that.
to seek to the job. Yeah.
Okay. And so to be a driver's rehabilitation specialist, do you have to be an occupational therapist? Are there other kind of
You do
professions
not
that do it?
have to, but I would say 99% of us are because that's our kind of our bailiwick. OTs work in with the skills of ADLs. There are other folks who are other allied health, a couple of PTs. There are some nurses, but the majority of us are OTs. We do work pretty closely. There are driving instructors in our field who
Okay.
look like at a regular driving school, but their primary caseload that they see are people with disabilities, and they usually work in conjunction with a program like ours.
Okay.
So,
And then, so what's the process to become a driving rehabilitation specialist?
well, it's a lot of studying,
Is it?
but it's not too bad. It really, you have to mentor with someone who is in the field. In our program, I was lucky that we had somebody already in my position, and I was able to mentor her with her. You have to have a certain number of hours of actually performing these evaluations and working with these clients before you can even take our national examination.
Okay.
It is a national exam. We have to take it. We have to keep up with our continuing education credits. It's actually pretty more rigorous than it was for my initial occupational therapy
Mm-hmm.
evaluation. But that's important. We're really out there making sure folks are safe on the road. I mean, that's one of the biggest risk areas for our clients. So we want to make sure that we're up to date on current technology for vehicles,
Mm-hmm.
current knowledge about rehabilitation and recovery process, especially, if we're talking about strokes, all the new things that are happening with medicines and just all different type of therapeutic interventions. We have to stay up with that so that we see how that impacts driving. And it may or may not, but
Mm-hmm.
we want to make sure we know those things.
Okay.
Yeah.
And so, so my limited understanding is you have an evaluation and you have rehabilitation. Are those kind of the 2 areas that you function as in your job?
Mm-hmm. Well, in the situation with folks with strokes,
Mm-hmm.
what typically happens is we do our initial clinical evaluation, and it's similar to what folks usually experience in a regular outpatient therapy setting, whether it's OT, PT, or speech, except ours is ramped up more to really, the focus is how does this impact driving? So if physically someone has problems with weakness on one side versus the other, we are assessing, all right, so to manage a vehicle, to control the steering or the pedals, if I have weakness on my right side, can I use my right foot to drive? Those kind of things. So we're looking very specifically at their physical skills, strength, range of motion, reaction time for gas and brake. We are looking at kind of what's their posture. Are they coming to us from a wheelchair dependency, or are they using any other type of assistive device? So we're having to consider that. We're looking at vision. We do a very thorough vision evaluation. We're not only looking at visual acuity, but basically how their brain processes what they are seeing and makes sense of that. And then we do a very thorough assessment of cognitive abilities. And from a return to driving perspective, the cognitive aspect is going to have the biggest impact on return to driving. From a physical impairment, there's all types of adaptive equipment that we can use to modify a vehicle. So when we're doing that evaluation, we're already thinking, okay, this is what I can do with this person as far as adaptive equipment. So I know I can manage that, but someone has to be cognitively able to comprehend the training for using that new equipment. It's new learning. Okay. But we are just looking at processing of information, just all of those kinds of things. So it might be very similar to what some folks may have experienced taking a Neurocyte test, a battery of tests that looks at all different parts of thinking. Once we complete that evaluation, and on average, it takes about 2 hours. Sometimes it can take longer than that. Sometimes it can take less than that. But we don't rush people. It's not something, they're not coming in and we say, you only have an hour to get this done. We're looking at the entire evaluation at one setting. If they are able to pass the evaluation and we feel like, okay, I think driving is a possibility, we will go out and do an actual on-road assessment. So we actually get into a car. It is not a simulated training. It's in a vehicle. And we drive. We go all over. Our standard route is here in Greenville, and we're in all types of traffic. We start out kind of in a secure residential area where they can get used to being in an unusual car. We take into account, many folks have been driving the same car for 10 years. And so getting into a new car is very unusual, and it's kind of scary. So we start out really low key, not a lot of stress. Let's just get used to things. And that also gives me an opportunity to look at how are they going to do? Are they going to be really anxious during this drive? Do I need to kind of support them in a more emotional way from the anxiety? Or is this somebody that's like, oh, this is old hat. I've been driving for 60 years. I've got this, and they're going to have more confidence. So it helps us kind of gear the rest of that driving session with them. And then just based on how they do, we just keep adding progressively more difficult driving opportunities. We do interstate driving. We do a lot of urban commercial driving in and out of parking lots. We'd like to take people into Walmart parking lot and out of Walmart parking lot. I think if you can go in there and park and drive in Walmart parking lot, you're doing pretty well. It's a pretty good indicator. There are Home Depot. And then some folks at the end of that drive, they've done great, and that's the last we see them. We say, you look great. our recommendation back to your physician is that, yes, you can return to driving. We don't see any reason to restrict your driving, that kind of thing. And that may be the last time we see that person.
Mm-hmm.
There may be other folks that as we're doing the drive, we see things that, okay, now we need to work on these areas to get back to driving. Now, some of those folks come to us for that training or that rehabilitation, and we'll do it in the car. There
Mm-hmm.
are some folks that we may say, you know, we're going to send you back to PT for a little bit to work on reaction time, or we're going to send you back to OT to work on your scanning, or something like that. Let's go back, let's work on this for a few weeks, and then let's come back and recheck. So for most of our stroke clients that we see, it's not a determination, I would say not all, but the majority of them, it's not a determination of yes driving or no driving, it's when.
Okay.
We're looking at when in this process can we return to driving? And if we return to driving, do we need to have new restrictions? Does that need to, as I said, look at using adaptive equipment, which we would train them on? Or is this someone now that may have some potentially visual changes that driving at night is no longer feasible for them? So we'll say, okay, you're driving in the daytime, but no nighttime driving. But, as I said, most of our stroke clients, it's really a question of when do we return to driving?
Okay. And so it's not necessarily an all or nothing thing with one test and that's it. That's been my experience, especially with you personally, is that maybe there are some issues that could be addressed and improved. There are some recommendations on, all right, we're going to change, just like you said, we're going to change how you had been driving. And so that was just for me, I would say, I have a background as a physical therapist, but there were some things to me that I was like, oh, that of course I've been driving, but I didn't really, process that there's just things that if you're not feeling up to snuff, just driving around, you might let cars be sure there's an open space, make some adjustments, and that those are some adjustments that you have to recommend to people. All right, now you're going to be sure that you leave enough time to pull into traffic and some of those things.
Exactly.
And another thing that was, again, I'm a little embarrassed that at the time I was naive enough to be like, oh, which is exactly what you said. Oh yeah, it's not the physical limitations that necessarily are the things to be most concerned about with return to driving. It's the thinking things.
Exactly.
And so could you talk a little bit about what are those things that maybe we did automatically or before a stroke, or that I'm doing automatically now, that can become problems that need to be addressed, and that you that are part of the testing and part of the things that you might refer someone back to OT or to speech therapy about?
Right. I would say probably the biggest limitation for folks from a cognitive standpoint would be attention. Okay, if someone is having problems paying attention in a static environment, in the therapy environment, or at home, those kinds of things. If someone's always having to remind them to pay attention or to be able to focus for more than a few seconds or a few minutes, then that's going to be a big barrier to return to driving. Our attention has to be, we have to be on target all the time when we're driving. And we all know that we have lapses in attention. Think about those times when you're driving along and all of a sudden you think, I don't remember the last 10 minutes at all. Okay. But your brain is automatically processing that information. When we have a stroke and we're not doing that automatic processing, when it doesn't come smoothly and fluidly for someone, it's not instinctual, from a therapist standpoint, that's our job, is to navigate them back towards where it becomes more just instinctual. They're just attending to their environment, not only what they're seeing, but what they're hearing. We have to be able to have good divided attention. That really, for driving, think about it. We're driving, we're thinking, okay, I'm going to Walmart. Now, what's my honey-do list? What are the 3 things that my wife told me to pick up to get, at Walmart? Or, all right, I'm going to pick up all of these items for a project I'm doing at home. So I'm trying to fix the bathroom faucet. So I'm rolling through that in my mind of what I need to pick up. The radio's on, but I'm also having to pay attention to traffic. And, then it starts to rain. So your attention is just divided in multiple ways, but you're still, that subcortically, we're still attending to what we need to do to stay safe for driving.
Mm-hmm.
The thing that happens for most of our stroke clients, the population tends to be an older population. So they have a long history of driving and driving safely. And they're not thinking about it. It's nothing they've had to think about before,
Mm-hmm.
not since they were 15 or
Right.
14 or 11,
Right. In South Carolina, yes.
Yes. So, now here I am and I'm 70 and I've had a stroke and I have to think about this driving process. So that attention is really the biggest area that I would say we're concerned about. And then along with that, just the processing speed. How fast are we processing what we're seeing? If there's a delay in that, okay, I see a UPS truck stopped in front of me. I need to start slowing down. I need to check my mirror and see if I can do a lane change and get around them. So prior to someone's stroke, that just was automatic. It just boom, boom, boom happened.
Mm-hmm.
But now I see it and I'm processing it, but it's an actual, there's a delay in thinking about those steps.
Mm-hmm.
Well, by the time I've thought about it, I'm on the back of that UPS, right?
Mm-hmm.
So those are the areas that, for the most part, if we see areas of concern and we're sending folks back to rehab, that's going to be the 2 big areas that we're seeing. And then the other would be just visual skills, just their visual search, making sure they're scanning, they're moving their eyes, and they're looking at their environment, because you're not going to process what you don't see. So if you're not looking, if you're not trying to take in that information, then you're not using that to make those good decisions for driving.
And so then who are the team members that address some of these parts of, so that visual piece tends to fall in with the occupational therapist, correct?
Correct.
And then what about those other processing and thinking
right
skills?
So the processing speed and the attention, that falls, excuse me, I think that's kind of a dual role of OT and speech together. But it also, we include our physical therapist in that. It's really important. And I know you do this in your clinic. While you're doing those physical skills, you have to include that cognitive component. We need to load them to be able to do all of those things automatically. Driving does have a physical component to it. So I have to have good coordination to be able to use my foot and use my both hands to steer. It's a bilateral coordination activity. If it's not, if someone now is a hemiplegic and they're only using one side of their body, it's very possible they're now using a non-dominant side. So maybe they're right-handed and they're now learning to use the left side for driving. So the therapist that would be responsible, we would really have the physical therapist work on those left-sided skills and add in all those other things that the OT and the speech ask you to add in to that therapy session. So, it's hard to piece it out. It is a team. It really should be a team approach.
And then when they finish an evaluation with you and you feel like there are things that need to be worked on before this person would come back and evaluate again, is that how you do? You go through the evaluation again?
Right.
So you write out some specifics to send to their team?
Exactly. Yeah, we provide recommendations. Sometimes that may be written, sometimes it may be a phone call. Because I'm in a rehab setting, and if somebody wants to go to therapy here in our clinic, I'll actually walk upstairs, introduce the client to the therapist and say, this is what we're working on. these are things we need to address. But we always try to follow up with whoever we are referring out to. Because, driving is not necessarily something that as therapists that we were taught about in school, and they're still not really teaching about it.
Okay.
So therapists don't, a little bit more, but not a lot. So therapists really don't know, all right, well, what do I need to work on to get this person back to driving? So we try to kind of guide them. Not all clinics have fancy equipment, but I don't think you need fancy equipment to work on all of these things. That's my bias. That's how I've been a therapist for a long time. And we, I trained learning therapeutic use of self. So you got yourself and you've got whatever's in your kitchen. Let's figure out how that's going to work and help you,
Right.
But, if somebody has access to a lot of equipment, that's great. We can give recommendations on how to use that as well. But yeah, it's a team approach.
And then, so that's more sort of like a traditional therapy setting, but incorporating the concepts that are kind of revealed in your evaluation.
Right.
So then what is specifically driver's rehabilitation? Because that's another piece of what you do, right?
Right. Yes. So sometimes we're doing that in the car.
Okay.
And we're putting folks in situations where we're working on those skills. More likely it's happening if they're using adaptive equipment.
Okay.
We're doing that actual training in a vehicle. We're usually starting in a parking lot, introducing to them to the equipment and that kind of thing. And again, that process, depending on how they take to it, may happen fairly quickly. Somebody may learn to use this equipment quickly and progress through that training fast. There are others who are not as comfortable with new technology or new things and may take longer. I would say most of our gentlemen who have had an opportunity to drive different types of equipment. Now that'll be changing in a few years, but our current population, I don't see a lot of ladies that have driven like forklifts or tractors or that kind of thing.
Sure.
But the men have had the opportunity, so they usually feel a little bit more comfortable with that equipment. But then that is changing. I do see that changing. If someone is really sensitive to the equipment or anxious about it, we can start folks on our simulator. We have a simulator that we can put the adaptive equipment on there and start that process in an environment where even if we wreck, it doesn't matter. We're not, we're right there.
Oh, that's nice.
Yeah. So we can start in that process, but really to get the meat of the training, it's going to happen in the car. Now, there are folks that we do work with, they're working on their cognitive skills, and we try to do some of it in the car and some of it in the clinic. Unfortunately, everything we do in the car is not covered by insurance, so I try to be very cognizant of the financial burden for folks. So if I have somebody that we kind of need to split that process, we try to, be aware of that and do it half and half in the clinic and half in the car, or, at least, a few minutes in the car and the majority of it in the clinic, so that we're minding their dollars, because it can become burdensome.
So what does that car look like? Could you explain it a little bit? And maybe I'll get a picture. If you have a picture, I can put it at the end of this video. Yeah, I just, so you could talk about it. I think it's pretty cool.
Yeah. So we have 3 vehicles. We have an Avalon. It's a 2010. None of our vehicles currently have all of the current technology. That's our goal. Our next car, I want it to be really up to date with all the new, lane monitoring, collision assist, those kind of things. But currently we don't have that. We have a 2010 Avalon. We have a 2014 Malibu, and I have a 2014 Toyota Sienna.
Hmm.
Now, in both the Avalon and the Malibu, they're standard sedans, and we can take our adaptive equipment in and out. So if
Okay.
somebody's getting in to drive in it and they don't need adaptive equipment, it's not in there.
Okay.
So they don't have to worry about all these other things that are in the vehicle. But if they need it, we have it available. We have options to try out. There are 4 different types of adaptive equipment if you're looking at hand controls.
Hmm.
So we have those. We have all the pedals we can put on. If somebody's learning to use a left foot accelerator, we have that. That's
Okay.
basically where the current factory issued gas, instead of being on the right, it's going to be on the left of the brake.
Okay.
So we can kind of move those things around, and we have that. But as I said, it's not in there if they don't need it. Our Toyota Sienna, it is designed specifically for training people who need to drive from a wheelchair or in a
Okay.
wheelchair.
That's cool.
It has a seat, the front seat actually raises up and turns around so a person can transfer from a wheelchair into the seat, and then it swings back around towards where they would drive.
Mm-hmm.
Or we can actually take that seat out and they would drive from their wheelchair.
Their personal chair.
Right, right. And that would be somebody, driving from the factory issued seat is always the safest way to drive.
Okay.
But there are people who are not going to be able to transfer easily.
Mm-hmm.
And so it just is more efficient for them, and helps them be more independent to drive from their wheelchair. In that case, if they're going to be driving from the wheelchair, we have to make sure that the wheelchair that they have meets the specs to be safe for driving from. And not all wheelchairs are safe to drive
I'm sure
from.
not. I'm
Right,
sure.
right.
Yeah.
So that's another portion of us working, another team member. We work with our wheelchair seating specialist and the vendors who are supplying the wheelchairs to make sure they have the safest equipment possible. But that van, we also can do any type of hand control, but it also has what we call reduced effort steering and reduced effort gas and brake. So you know how when you get in a car and if you're making a turn, you're turning your steering wheel to the right. And then once you make that turn, if you let go of the wheel, it automatically goes back and the wheels right themselves, center up. Well, in our van, we've taken that away. The reason we've taken that away is because the people that are driving from the wheelchair generally are at a point where they have minimal strength, minimal abilities to manage that resistance. So what it's doing, it's taking away the resistance on that steering.
I see. Okay.
But then they have to do more turns
to get it back to be right, to right the wheels.
Yes,
Okay.
yes,
That's
exactly.
Interesting.
And then the gas and brake, the same thing. It's not the same amount of resistance that you and I feel in our car. It's a reduced effort on that gas and brake, so that it makes it's very easy to manage those pedals.
Okay. So in terms of like hand controls, if we think about somebody who's a stroke survivor who's had one side affected, what kind of hand controls are generally, do you find that maybe are helpful when somebody feels they need something, or if you feel like it would help them? Right.
So I'd say the most of the hand controls, if someone has no use of one side of their body, okay, if they have no use of the left side, it's not going to make that much difference in their driving, except that from a steering perspective, they're only going to be using their right hand. So we may add a spinner knob, a knob to the steering wheel that helps with the turns. If someone has lost all use of the right side of the body, we are potentially looking at, like I said, a left side accelerator, which would move the gas to the left side. And again, they would have a steering knob.
Okay.
But I would say the majority of our clients, and you see this, most of the strokes, I don't know what the percentage is, but their lower body usually works better than their upper body.
Mm-hmm.
You know, they get better return in the legs. So what we will see is that somebody can still use their hemiplegic foot to use the gas and brake. They have enough movement or enough reaction time to use that, but they're not using their right hand to steer. They're going to have to use their left hand.
Okay.
Okay. If we're looking at a combination, if they cannot use either foot, we would be looking at using a hand control, a gas and brake. We have both. They can either be on the left side or they can be on the right side. And then the other hand would do the steering if they have no ability to use their legs, but they can use their hands.
Okay.
Now, there are other types of equipment that are available out there for folks to drive. We don't have it, but there are what we call steering rings, or the accelerator gas ring. So it looks like a ring that's either, there are two types, one's on the outside of the steering wheel or one's on the underside of the steering wheel. So the person can use their two hands and they're squeezing the original steering wheel and the new steering wheel, okay, that's attached. So it's like a double, and that squeezing manages the gas and brake, okay? So it helps them go faster or slow down. The only problem with that is you're looking at a huge leap in the cost of that type of equipment.
Mm-hmm.
So an average set of hand controls or a left foot accelerator is probably maximum going to run somebody about $3,000 on their car. When you get into higher level equipment, a steering ring or what we call drive-by-wire, think about Christopher Reeves driving. And so it's really high-tech equipment that's modified with all these electronics. You're talking $10,000 and more for driving.
Okay.
So luckily for most of our stroke clients, they don't need that amount of equipment.
So just out of curiosity, when you're in the car, what controls do you have as the instructor or as the specialist?
The best control we have is this.
Okay.
Our head,
all right.
And our eyes, where we're watching, we're vigilant. But we have a brake. We do not have a gas. We've all been trained to be able to take over management of the car, both steering. I can reach over and grab the steering wheel and manage that. I have some equipment we can put on to do the acceleration, but we don't usually use it because we start out in such a secure environment. Before we really get out on the road, the client usually has a pretty good grasp of how to manage that equipment before we're getting them into traffic.
Gotcha.
So, we're trying to manage our risk both for ourselves and for our clients.
All right.
Yeah.
Well, so if somebody was interested in a driver's evaluation, how would they go about finding out if there's someone near them that they could do that?
Sure. So our national organization is called ADED, ADED, and it's really just the Association of Driver Rehabilitation Specialists. But if they would go to www.aded, and that will come up with our website, and then they can just search for a provider. They can search by state. They can search if they know somebody in particular, they can search by a name, but usually search by state is going to help folks find somebody in their area. If there's nobody in their state, I would say just try to pick somebody in a closer state. And then contact them and see if, again, some programs do travel. So, they may not have to drive 500 miles to another state. Maybe somebody travels. I know that happens quite a bit out west,
Okay.
because people are much more spread
Spread
out.
out.
Yeah,
Sure.
yeah.
And so does a person need any kind of specific referral in order to get an evaluation?
So our program requires a doctor's referral because we're a hospital-based program.
Okay.
I would say, I would guess that almost all of the programs want a doctor's referral
Hmm.
because it is a medical issue.
Okay.
And we're trying to make sure that we're making the best decision for this client from a medical standpoint, and a safety standpoint.
Hmm.
In most states, the doctor has a final kind of say-so to the Department of Motor Vehicles on driving.
Hmm.
So even if a client is not required to have a referral, my guess is their state Department of Motor Vehicles will require a doctor to sign off.
Gotcha.
So we do require a doctor's referral. And if we are seeing someone that requires equipment, we try to walk folks through that process with the DMV.
Okay.
And because we do have to have those restrictions placed on somebody's license.
Okay. So there's sort of
So,
legal pieces that go
right,
because this is that we carry a
right,
license
right,
with our
right.
particular state. Okay.
Yes. So in South Carolina, we have that doctor's referral. We do the evaluation. We've trained them on the equipment. And then the patient is actually issued a packet of paperwork that has to be completed by the physician.
Mm.
And that's where they kind of get that final say-so, to say, these are all their medical conditions. These are all their meds. These are, everything that's going on. And pretty much the last line in our form and in most doctors' forms is, do you think this person is safe to drive?
Okay.
And at that point, in South Carolina, and again in most states, it's then reviewed by a medical review board that's made up of physicians from all practices. But generally, if a client is being seen for us for a stroke, that paperwork would go to a neurologist.
Okay.
Or a rehab doctor.
And that's a
do
board of
that.
physicians for the
Yes,
state because the
yes,
state does our licensing for driving.
yes,
Okay.
yes, yeah,
All right.
yeah.
So then a
And it's
person could expect that that they probably are going to need a physician's referral, that there's some paperwork generated out of all of this that's
yes,
returned back to the doctor.
right.
That a portion, like so in South Carolina, a portion of this could be covered by insurance.
Yes,
Because you're an occupational therapist and you're providing an occupational
yes,
therapy service, right? I feel like
correct,
that's kind of
correct.
was my understanding.
Yes,
But then there may be nuances depending on an insurance company and a state that they live in as well. But in
yes,
general, those are some things that a person could expect to be a part of that process.
correct. Yes,
All right.
yeah.
All right. Is there anything else that you would want to share about getting back to driving that I haven't asked you about?
Well, yes, I would.
Oh,
Okay,
fantastic.
so it's been my experience, and it's probably been your experience as this way as well, is that when the person first comes in for outpatient therapy and we ask them, what are your goals? It's always, I want to drive. And not thinking about the process or the steps that we have to go through to get to driving.
Mm-hmm.
Driving is kind of the end of that rehab process. And that's what I want people to understand, is to trust your therapist. And if your therapist says, I don't think you're quite ready for that, I think that's a great goal, but these are all the things we're going to work on first to get you there. And that, jumping right back in the car after the stroke is probably not the most, it's not the safest thing to do. All right. And don't put yourself at risk or your family at risk for any other harm. Let's manage all the steps as they need to go. And then, driving's the final part of that picture. So
I would agree with you. That is my
yes,
experience. So
yes.
All
Yeah.
right. So I appreciate you
Sure.
coming online and sharing all your
Sure.
experience. I knew that you had a lot of experience. I didn't realize you had been
A
doing
long time.
yeah, you've had a lot of opportunity to see technology change
Yes.
and the equipment that you get to work with. I mean, I'm
Right.
sure has changed greatly.
Yes. Yeah.
And so that's exciting.